I believe safe patient handling is best described as policies, procedures, and support which enable healthcare workers to mobilize patients in a way that prevents caregiver injury and promotes patient safety.
Safe patient handling is a very complex program. It's something that addresses and touches every patient from admission through to discharge. It affects all of the nursing staff and care staff, and to treat it as anything other than that is to make a big mistake. This is something that is very significant, both from a financial perspective and also from an outcomes perspective.
I started my career as a wound care nurse, and what I found was many of the patients who came to me were of size, larger, heavier, obese patients. I became certified in bariatric nursing shortly thereafter. And then what I learned was that many of the reasons why there were skin injury around larger, heavier patients is because caregivers were afraid to lift, turn, reposition patients. And it seemed to me that safe patient handling would be a way to navigate around some of the issues that we saw managing those non-reimbursable events among the obese patient. What I've learned since then is it's not just the obese patient that poses issues around safety, it's all patients. Anytime we're expected to lift, turn, reposition patients, I often think about the triad of danger. If the patient's immobile and we're afraid of lifting, turning, repositioning because we're afraid of injuring ourselves, then the patient develops those immobility-related consequences of care.
Behind every injury, there's a productivity increase crying to get out. And so it really comes down to the idea that individuals want to get the job done, and especially individuals in the healthcare arena think about the patient first. They don't necessarily protect themselves. In many cases, they put their patient in front of themselves. And so what we see is a crippling epidemic of the nursing staff becoming the patients themselves.
Leading experts in the safe patient handling movement, Martin Cohen and Mary Matz, both explain that the pushing and pulling action regularly performed during the repositioning of patients is the most commonly cited single cause of occupational injuries in the healthcare sector today. Historically, manual handling was the standard of practice. To put this in context, the leg of a 250-pound person generally weighs about 39 pounds. Clearly, most lifting tasks in healthcare involve much more than 35 pounds of body weight. In years past, we didn't have the science to understand the threat of manual lifting. We now know that 75% of the time we lift, push, pull more than 35 pounds, microfractures occur to the vertebral end plates. These go on to heal but create scar tissue which accumulates over time and eventually threatens the function of the end plate. This does not mean that 75% of manual lifts produce acute injuries. Rather, they produce these cumulative injuries for reasons just described. So when acute injuries result as expressions of cumulative damage, recovery is especially slow and unpredictable. Let me share some data from the Centers for Disease Control, the CDC, which illustrates obesity trends in America from 1985 to 2012. As I do, let me describe a study conducted by TUI Maine, which suggested that the average nurse during an average 8-hour shift lifted, pushed, pulled an average of 1.8 tons. That study was conducted in 1997. Let's stop and look at the 1997 CDC data. As we move through the data, notice the increasing prevalence of obesity. Further today, many caregivers work 12-hour shifts. This raises the question of what weight caregivers lift in today's healthcare environment on a daily basis. Consider a few of the typical risk scenarios, such as transferring an obese patient between a chair and a bed, or transferring a patient between a chair and a shower or bathtub, or laterally transferring a patient between a bed and a stretcher. Manual handling in any of these circumstances is unsafe, but especially with a patient of size. As part of the Deficit Reduction Act of 2005, the Centers for Medicare and Medicaid Services, CMS, recognized what are referred to as hospital-acquired conditions and have placed provisions in the inpatient prospective payment system for non-payment if certain circumstances exist. Healthcare planners are scrambling to find solutions to the non-reimbursable events as described by CMS. The underlying contributing factor in at least 4, arguably 7 of these events is immobility. So if we can manage immobility, we may be able to mitigate some of the economic consequences of these events. The first immobility-related consequence of care, which comes to mind, is the pressure ulcer problem. Pressure ulcers are costly economically, both from a reimbursement and a liability claim perspective. Other immobility-related patient safety issues are DVT, readmissions within 30 days, hospital-acquired pneumonia, arguably catheter-associated urinary tract infection, arguably surgical site infection, and definitely fall-related injuries. In fact, in a 2012 Joint Commission publication, it was reported that the issue of falls is particularly important to healthcare today. In an analysis of over 7,000 inpatient falls, researchers found that more than 25% resulted in some degree of injury. A number of authors indicate that the safest approach is the approach that is truly caring, a safety-based program which is comprised of trained healthcare workers who use appropriate mechanical lifts and repositioning devices rather than manual handling. One study documented a 49% reduction in patient falls related to lift and transfer activities using the processes I just described. These practices also free healthcare workers from the burden of lifting patients, so they can devote their energy and mindfulness to more meaningful patient care. The goal is to let healthcare workers provide healthcare and let proper, safe mechanical devices provide lifting. This really is a good first step to protect both patients and healthcare workers from injury. As the New Jersey legislature noted in a statement of findings, and I quote, "Studies show that manual patient handling and movement negatively affect patient safety, quality of care, and patient comfort, dignity, and satisfaction. And it is appropriate public policy to minimize unassisted patient handling." It is important for healthcare facilities to understand that across the nation there is a legislative movement mandating safe patient handling measures. 10 of the 50 U.S. states already have legislative mandates or resolutions which address safe patient handling. For example, the state of California passed Assembly Bill 1136 in October 2011, which mandated specific requirements towards safety in the general and acute care settings. On June 26, 2013, the American Nurses Association introduced the Safe Patient Handling and Mobility Interprofessional Statement. This is a wonderful and comprehensive document which describes the what and why of safe patient handling and mobility. And it's the first time a national professional organization has initiated such widespread support for safe patient handling. 2 months later, the corresponding implementation guide was released. The implementation guide provides a step-by-step how-to guide for implementing a safe patient handling and mobility culture.